Hi, I'm Eric Levene. I'm a partner at Allied Physicians Group and a practicing pediatrician in White Plains, New York. Thank you all for joining this evening on this very hot day in New York. We really hope we'll answer most of your questions tonight. Whether you're expecting your first child or your third child, or have recently had your baby, this is a very exciting time for you, but also can be quite stressful and it's certainly tiring. As a parent, you're going to be making a lot of important decisions, not just for you, but for your child. But your best decision really has been to join here and get some really good information about breastfeeding. At Allied, we are an independent pediatric practice in the lower New York area. We're here to answer your questions. And with that, let's begin. And we'll introduce the participants. Dr. Macaluso.
Hi, I'm Dr. Lauren Macaluso. I'm a board-certified pediatrician and lactation consultant with a specialized medical practice in New Hyde Park on Long Island, focused exclusively in breastfeeding mom and baby care in partnership with Allied Physicians Group.
Dr. Shaer.
Hi, my name is Jennifer Shaer, and I am a pediatrician practicing in Riverhead and Southold on the east end of Long Island. I am also a lactation consultant, breastfeeding specialist, and the chief medical officer of Allied. So I'm excited to chat with everybody today. It's such a great idea to practice. You know, everybody always spends so much time getting ready for labor and delivery, but that ends really, really fast. And you often think like, oh, well, I'll just see how breastfeeding goes, but breastfeeding could last a really long time. So getting prepared is a good thing. So I'm glad everybody's here.
Thank you. Dr. Visentin.
Hi, I'm Dr. Lisa Visentin. I am also a board-certified pediatrician and a lactation consultant, and I have the pleasure of working with Dr. Jennifer Shaer, doing both general pediatrics and breastfeeding medicine in our offices out in Riverhead and Southold. And I'm glad that everyone's able to join us tonight, and hopefully we can answer lots of your questions and get this evening off to a good start.
All right,
okay.
Let's get started.
Excellent. So I'm going to take the lead here. First slide is about why breastfeed. So all major US and global organizations medically recommend that babies be exclusively breastfed for 6 months, with continued breastfeeding after 6 months while introducing new foods. The American Academy of Pediatrics states that there's no upper limit on the duration of breastfeeding, and no evidence of psychological harm from breastfeeding into the 3rd year of life or longer. The American Academy of Family Physicians recommendation includes the ongoing benefits of extended breastfeeding, including continued immune protection, better social adjustment, and having a sustainable food source in times of emergency. Breastfeeding is designed to meet the needs of babies and breastfeeding parents. It has the right amount of carbohydrate, protein, fat, and water for optimal development. It's easily digested and dynamic. It changes in composition throughout the day and over time to match the needs for our growing babies. It has bioactive factors that protect your baby from infection, modulate their immune system, and affect growth and development. Next slide, please. So breastfeeding, it is normal. It's not best. It's not like it's this special magical sauce. It's just normal. It's what our babies are meant to do. And it's so much more than just food. And in the ideal normal vaginal birth, we deliver our babies and baby goes directly to mom's chest within the 1st hour of life. Newborns that are kept in skin-to-skin contact on mom's chest have better body and skin temperature stability. And believe it or not, blood flow to your chest as a new mom is greater than the blood flow to your brain. I think that's pretty darn amazing how important this part of your body is. Just normal physiology and biology made it this way. Breastfeeding is warmth. So newborns also utilize their senses and instinctive abilities to breastfeed. They actually have the scent of amniotic fluid on their hands when they're born. They actually lick their hands and work their way towards the breast. Also, mom's sweat and secretions from the glands on the dark circle of your breast, also known as your areola, smell and taste familiar. It's similar, the smell and taste of these secretions, it's similar to amniotic fluid. So babies will actually lick their hands and it helps find their way through scent and taste to help them find their way to the breast. They also have a visual preference for contrast. So there's this big dark circle areola on your breast, which is like a bullseye saying, eat here. It is normal physiology. It's ready and waiting for them. And all of these instinctual inputs make breastfeeding normal and instinctual for babies. Oxytocin hormone is produced both in moms and infants' brains during breastfeeding. It's known as the love hormone, and it helps also with bonding. Early milk is known as colostrum, kind of a hard word to pronounce. People are going to be saying that word to you a lot in the hospital and mentioning it because it's your early milk, and it comes in small amounts. It's high in antibodies, and it protects your baby from what you're both exposed to. The average intake of colostrum in the full-term healthy newborn is only about 1/2 to 2 teaspoons per feed in the first 24 hours. And then it continues to increase in response to your infant's needs. Many of us question our abilities to make enough milk for our babies and feel the need to utilize formula as more food. But remember, breastfeeding is much more than just food. It's human instinct, it's warmth, it's protection, it's bonding, and it's what we're supposed to do. But it may not feel very instinctual right about now. Most of us are facing a tremendous number of barriers to breastfeeding. We're living further away from our extended family, and it's really challenging to find support. Many of our own mothers didn't breastfeed, and society hasn't fully embraced this as normal yet. Most of us are having a hard time finding evidence-based, consistent information about breastfeeding. We're receiving a lot of mixed messages and don't know who to believe. We're returning to work with varying levels of support to establish breastfeeding or to establish a flexible work plan to breastfeed and express milk. And when breastfeeding problems occur, we don't always know where to turn. This is a truly monumental time in your life. It is a physical, mental, social, and emotional climactic transition, which can be really challenging to handle. And it's known as the 4th trimester. And goal here is to remember it is normal. There is evidence-based help out there, and you're meeting it right here tonight. And this is when breastfeeding is so much more than food. You burn about 500 extra calories a day with breastfeeding and usually return to your pre-pregnancy weight more quickly. You mobilize your fat stores, reset your metabolism, and have a decreased risk of diabetes, high blood pressure, and cardiovascular disease in the future. Oxytocin, that love hormone that I mentioned that helps with bonding, it also stimulates smooth muscle contraction that lines the breast milk producing cells and the uterus, so you have less bleeding after delivery and less anemia. You're less likely to ovulate while breastfeeding exclusively, which helps with child spacing. And you have a decreased risk of ovarian and breast cancer. Your baby also has a decreased risk of infections, including ear, gastrointestinal, and lower respiratory tract infections, and a decreased risk of sudden infant death syndrome, childhood obesity, and diabetes. It's important to include that the breast and breastfeeding is not perfect. Some of us have physical, social, and emotional reasons where we're unable to breastfeed, have a need for alternatives, or make a choice not to. It's recommended to supplement a baby with expressed breast milk, safe pasteurized donor milk, or formula if there's a medical indication, such as inadequate milk intake in the baby, with signs being excessive weight loss, inadequate peeing and pooping pattern, or excessive jaundice. Many moms and their partners express frustration, stating, "I'm told I should breastfeed, but I'm receiving little to no hands-on consistent help to execute this." Hands-on, time-intensive mom and baby care should be universally included in medicine, but we're just not there quite yet. It's our goal to help support you and help you reach your goals. And this should be through informed, educated, non-judgmental group decision-making and thorough care with you and your family. Next slide, please. So how it all works. There's 4 major hormones in lactation: estrogen, progesterone, prolactin, and oxytocin. Estrogen and progesterone are released from the placenta during pregnancy. They increase the size and number of milk ducts in your breast. Once your baby's born and you deliver the placenta, these hormones decrease and prolactin increases. Prolactin is your milk-making hormone, and it's secreted in like a pulse-like fashion from your pituitary gland, and it rises with suckling. So the more feeds you do, the higher level of prolactin. Milk production runs by demand and supply. A common phrase we tend to use is an emptier breast makes more milk. So milk production slows when the breast is full and speeds up when the breast is emptier. And there are actually prolactin receptor sites on the walls of your milk producing cells. So when the breast gets full, these walls on the milk producing cells expand, and it changes the shape of these prolactin receptors. So prolactin can't enter the milk and milk production goes down. As milk empties, prolactin from your bloodstream can move in and stimulate breast milk production. Oxytocin, love hormone, bonding, neat stuff. It also stimulates the letdown or milk ejection reflex. A lot of people ask what that means in the office when they come in for appointments. And it's secreted from your pituitary gland as well. And oxytocin stimulates smooth muscle contraction that's around your milk-making cells. And they contract and it pushes milk down the ducts towards the nipple. So normal is pretty darn amazing. Feeding at the breast itself, latch, is most comfortable when you achieve a deep attachment. We found the best way to do this is by a deep asymmetrical attachment of your baby at the breast. I think this whole discussion of latch could be a whole nother huge talk in itself, which unfortunately we don't have a tremendous amount of time to go in as deeply into it. Thus, the QR code on the slide can lead you to a really great doctor-led, it's about a 10-minute video on latch created by Global Health Media. And it goes over strong, deep latching biomechanics. Most of you probably have your cell phone or maybe your partner's near you. You should be able to open up your camera on your phone and hover over the code and it'll lead you to the video. If you don't worry about it. You'll be getting an email from us tomorrow, whether you like it or not, and it'll be included in there. So don't worry if you can't open that camera and scan that code quite yet. There is not one way to latch your baby at the breast. Anything goes as long as you're comfortable and your baby is thriving. It's a bit of a dance between you and your baby, and it's normal to take some time to get to know your partner or partners if you have multiples, and to feel confident. And remember, we breastfeed, we don't nipple feed. So you want to get your baby deeply onto the breast. This way the baby gets more milk and you're more comfortable too. Some moms can achieve a deep, comfortable latch with what's known as laid back positioning. And this is where mom semi-reclines and the infant feeds on their belly while mom supports the infant's body. The baby's primitive reflexes, kind of like we mentioned with hands and with scooting up, and neonatal reflexes can help facilitate optimal breastfeeding behavior. Some moms find other commonly used positions to be comfortable as well, including a cradle hold, a cross cradle hold, a football hold, a side lying hold. You will see a lot of these names out there online. And also on this video that I shared with you, you're going to see a lot of these positions being demonstrated. And in practice, there's a wide variety of normal mom and baby anatomy, and one position does not necessarily fit all. It's really important to get hands-on help with latch. I strongly feel every family deserves a thorough breastfeeding medicine visit to maximize your experience, especially if you're not feeling comfortable. So feel free to call one of our offices for an appointment. Okay, I'm going to move on to the next slide. Medical organizations have been providing ongoing interim guidance statements as our experience with COVID continues to evolve and we continue to learn. The Academy of Breastfeeding Medicine has a COVID vaccination statement. Pregnant and breastfeeding women were not included in the phase 3 trials of the mRNA COVID vaccines. the president of the American Academy of Breastfeeding Medicine points out the importance of routinely including pregnant and breastfeeding participants in phase 3 clinical trials, stating it's time to protect pregnant and breastfeeding individuals through research, not from research. So I think one of the things we've learned during this challenging time has been the importance of consideration of including pregnant and lactating women in the future in research when it comes to clinical trials more. Early on, there was no clinical data regarding the safety of this vaccine in nursing mothers because of this lack of inclusion. However, there is little biological plausibility that the vaccine will cause harm, and antibodies in milk may protect the breastfeeding child. During lactation, it is really unlikely that the vaccine would enter the bloodstream and reach breast tissue. If it does, it's even less likely that it would get into the milk. In the unlikely event that mRNA is present in milk, it would be expected to be digested by the child, by the acid environment of a baby's GI tract. It's really unlikely for mRNA to survive that. Thus, it would be unlikely to have any biological effects in an infant. And we now have studies that demonstrated antibodies in the milk of breastfeeding individuals and in pregnant women who have received either the Pfizer or the Moderna mRNA COVID-19 vaccines. Most who took part in the study from the American Journal of Obstetrics and Gynecology were healthcare workers. The vaccines generated strong immunity in pregnant and lactating women, similar to that observed in non-pregnant women. And vaccine-induced immune responses were significantly greater than the response to natural COVID infection. And immune transfer to babies occurred via the placenta and breast milk. We're not exactly sure what this means for immune protection for breastfeeding or human milk infants, or I should say babies that are getting pumped, expressed human milk or breastfeeding. We're not exactly sure what this means for them. When a breastfeeding parent is exposed typically to a virus or a bacteria, our immune system generates immunoglobulin A antibodies. It's the best known antibody secretory IgA it is known as that transfers into breast milk. So what usually happens is you're exposed to a bacteria or a virus, your body mounts an immune response, you make secretory immunoglobulin A that is transferred in your breast milk, your baby swallows it, and it actually coats the mucosal lining of their organs, including their nose, their throat, their GI tract, their bladder, and along in correlation with other bioactive factors in breast milk, it helps prevent infection in an infant. The immune response from the vaccine we're finding is largely IgG, and we're not exactly sure how IgG acts on the mucosal lining compared to IgA. Many families have been asking about COVID vaccine and breastfeeding and are deciding to get vaccinated after informed decision-making together. I'm now seeing moms extend their breastfeeding duration longer as they were learning that the vaccine was coming out. They were so excited at the thought of trying to transfer antibodies to their infants that a lot of them were trying to prolong their breastfeeding experience, keep pumping so I can try to get milk to my child, which was a neat thing to see. I have seen some families, breastfeeding moms, pumping extra breast milk that they have and trying to give it to their toddlers to help with their immunity as well. If you have any questions or concerns, it's best to bring them up and make an informed decision with your healthcare provider. As a physician with an exclusively breastfeeding focused practice, COVID has definitely uncovered the importance of thorough mom and baby dyad breastfeeding medicine visits for me personally as a practitioner. At a time when many physicians across the country were faced with slowing of patient visits, my breastfeeding medicine practice has remained extremely busy throughout COVID. I've experienced a strong increase in prenatal visits with the shorter hospital stays that were going on throughout much of COVID. Families have been finding them especially helpful to go into delivery informed and empowered with follow-up ongoing after to establish breastfeeding and as needed throughout their breastfeeding journey. Breastfeeding medicine telemedicine visits have been really helpful as well during this time. It's a wonderful way to provide full counseling and answer questions thoroughly. And many patients have been asking me to continue it beyond COVID, and I definitively plan to do so. So now I'm going to hand it over to Dr. Visentin for how to get off to a good start.
Thank you, Dr. Macaluso. So as Dr. Macaluso mentioned, all of the wonderful benefits of breastfeeding, and I'm going to talk a little bit about how to get off to a good start. One of the first things to talk about is to kind of discuss these goals with your partner, with your medical team, so that everybody kind of knows from the beginning what your goals are. Those goals may change, and they very likely will change, but it's a good idea to kind of have a way to express that, help kind of figure that out for yourself, for you and your partner, and to let your medical team know that this is something that's important to you. Soon after delivery, as soon as medically possible, to put the baby to breast, as Dr. Macaluso had said, that's their first instinct. You want to make sure that you and your baby are medically stable, and your team is going to mention that to you, but ideally it would be in the first hour after birth that you would put the baby to breast. One of the best ways to get off to a good start is to start nursing early and often. So as soon as your baby starts showing feeding cues, to put the baby to breast. I'm going to go over what those feeding cues are in a moment. But basically, if you think that your baby is hungry, if you think that they're showing feeding cues, put the baby to the breast. Give them that opportunity to learn. Try to think of each feeding as an opportunity to learn for both you and your baby. As Dr. Macaluso mentioned, you guys are getting to know each other. And the more opportunities that you both have to practice and to figure this out, the easier it will get. Sometimes there is the tendency to be concerned, as you said, about having not enough milk supply. One of the best ways to increase your supply is to increase the frequency that the breast is emptied. And that will be achieved by putting the baby to breast often. Every time the baby nurses, that tells your body to make more milk. In general, the goal is to feed 8 to 12 times in those first 24 hours. As Dr. Macaluso mentioned, the volume that your baby is going to be taking initially is quite small. Their stomach is small. The volume of colostrum that they drink is quite small. That's why they need to feed very frequently. And so it's about every 2 to 3 hours. There will often be what's called cluster feeding, where a baby will eat much more frequently, maybe every hour and a half. That is completely normal in the beginning. It's also completely normal as a baby goes through growth spurts. That's one of the ways that your baby will increase your milk supply. Sometimes this makes parents worried because they think that the baby is eating more frequently than they were before. They think that something is wrong, but it's actually a totally normal way for your baby to increase that milk supply and meet its increased needs. Next slide, please. So one of our most common questions is my baby eating enough? And there are different ways for you to be able to know that. I hope you guys can see a little bit of what's on this slide. This is one of our breastfeeding logs. Most hospitals will have a version of this, and there are different ways to know that your baby is getting enough. One of the ways that you will be able to know is how often your baby is having a stool and how often your baby is urinating. A general rule of thumb is that for the each day of life old your child is, for the first week, they should have 1 stool and 1 urine diaper for each day. So for example, on day of life 3, you would expect a minimum of 3 poopy diapers and 3 urine diapers. This little breastfeeding log that we provide kind of gives parents a way to track it. There are lots of apps that parents will use to track stooling and feeding. Those apps can be very helpful. Some parents find them overwhelming, so I encourage everybody, if they want to try them. It can be helpful in the sense that you're going to be a little bit tired because you're not going to be sleeping as much. And sometimes it's hard to remember how many stools and how many urine diapers your child had. And if you can look back in the app, you can say, okay, they've met that minimum. And I know that that's one of the ways that I know that they can eat enough. However, I do discuss with parents if they find that they are focusing a lot on those apps and they're finding that it's causing more anxiety than it's really helping with them keeping track, then maybe that's not the best tool for them. And we discuss other ways ways for them to keep track of that. Your baby's weight is another way that you will know if your baby is eating enough. While you're in the hospital, the baby will be weighed every day. It's normal for a baby to lose weight in the first few days of life. Even up to 10% of their birth weight is considered normal. Some of that has to do with their fluid, the fact that they're not eating as much in the few days, but you should expect that your baby will potentially lose some weight in that first day or two after birth while you're in the hospital. That is completely normal. After those first few days, we expect them to start gaining back that weight, and most babies should be back at their birth weight by 2 weeks of age. So while you're in the hospital, that will be monitored, and they will talk to you about that. And then that's one of the things that you will happen when you go for your first visit, and then subsequent visits at the pediatrician's office, is that they will be checking their weight. Now, you're not going to be weighing them at home. So once you go home, the things that you're going to be looking for are the baby's feeding cues. Next slide, please. And so the feeding cues that you will be looking for, these are the ways, some of the ways that your baby will be able to tell you whether or not they are hungry. And some of this is figuring out your baby. Each baby is an individual. Each baby is different. Your first baby may be very different from your second baby in terms of temperament. These are some general feeding cues, but know that some of this is sort of figuring out your baby and figuring out what they're trying to tell you. There are both early and late feeding cues. Ideally, parents would be recognizing these early feeding cues and start to initiate breastfeeding at the first signs of these feeding cues. Some of the early feeding cues are fists moving to mouth. So you'll see the baby kind of start to put their hand to their mouth. If the baby is near the breast, you'll see them start to turn. They'll even start opening their mouth and kind of look as if they're trying to latch or nurse. Their eyes will start to open. They'll be more alert and active. They'll start doing lip smacking, which is kind of or sticking out their tongue, and along with the opening and the closing of the mouth. Babies may seem sort of not fully awake during some of these, and then as the child gets hungrier, then they'll start to cry. Crying is actually a late feeding cue, and so once a baby is really crying, they're really trying to tell you that they are hungry, and we are ideally looking to try to start breastfeeding at those first feeding cues. Some of the things that I talk about to parents in the visits is that it is often difficult to latch a baby who is very upset. And so we work on different ways to calm that baby to get them to latch on easier. It is much easier to latch a baby who's calm and showing those first early feeding cues. And so that goes back to feeding a baby early and often and trying to recognize those early feeding cues as best that we can. I believe next slide is going to be transitioning to talking about some of our more common obstacles that Dr. Shaer will discuss.
Right, okay. Thanks so much, Dr. Visentin. So I would say that despite all of your planning and preparing, that sometimes you are going to be faced with some obstacles. And what I want to do is address how to, first of all, recognize whether or not those are sort of normal bumps in the road that are expected, or if they're really truly obstacles where you need to get help. We don't want to let things defeat you. We want to set you up with the knowledge to empower you so that you can succeed. So what I thought I would do, because there's no way to possibly think about every possible problem that might arise, but I wanted to pick the 3 topics that seem to be the most common obstacles, that especially, they tend to be the most common problems that women face, but especially in those first few days. I think after you get discharged from the hospital, and Dr. Macaluso is right, the babies, you're now, because in this post-COVID world, people are being discharged from the hospital so quickly. You're not really having that much time to practice with the lactation consultant in the hospital, if you're lucky enough to even have one. And you want to really know what to do between discharge from the hospital and before you get to your pediatrician in those couple of days that it takes. And these are some of the problems that might occur in that gap of time. So we're going to talk about sore nipples, engorgement, and slow weight gain or a baby's weight loss. Next slide, thank you. So sore nipples. Now, this is something that when you ask women what they're most nervous about, most women are very concerned about how much it's going to hurt. And I think that Dr. Macaluso pointed out, you know, if you have it, this isn't, I like that. This isn't nipple feeding, it's breastfeeding. I never heard that before, but I like that. Really, breastfeeding is not supposed to hurt. Honestly, if we were supposed to have that much pain, our species really wouldn't exist. Women wouldn't tolerate living in that much pain. If a baby is latched on properly, there should not be significant pain. Now, with that said, in the first, few days or the first 4 or 5 days, babies are nursing a lot because they're really spending all that time to empty the breasts, to set your system up and the hormones that Dr. Macaluso described so nicely to produce the right amount of milk. And that means there's going to be a lot of time suckling at the breast in those first few days. So you can have, some chafe, some discomfort, but you should never have active bleeding, open sores, cracks, things like that. If that's happening, it is definitely time to get help. And quite frankly, I see sometimes women will just try to grit their, curl their toes and just let the baby suck through it because they think they're just doing what's best for the baby. But if the baby's not latched properly, they're probably not transferring milk well. So you're not doing anybody a favor by suffering. So if there is just some chappedness, women will often use some ointments that they sell a million different ointments that you could just use, or you could just express a little bit of breast milk and put that on. But if it is truly cracked, you need to get somebody to watch you latch, see what's going on with the positioning, and adjust from there. You'll know if your baby is latching properly if occasionally the first couple of sucks will hurt a little bit, but then if they take a few more and they get a little bit deeper attached, that pain should go away. Frequently, you'll also feel in the first few days some cramping as the uterus contracts down from the suckling. So those are signs that you're on the right track. So get someone to watch a feed if you're not in the regular sore area and you're in the cracked. If you can't get it right away, you can always hand express and feed or get a pump and bottle feed until you get somebody to help you. Next slide. So engorgement. Engorgement is another thing that can be normal or can be abnormal. And what happens with when your breasts are emptied, they feel soft and comfortable. And then as milk fills up, they can get large and heavy, and they can feel uncomfortable as the milk is filling. After a baby feeds, though, that should soften up and go back to sort of baseline. And it's this up and down of fullness and then release. And that's completely normal. But what will happen sometimes is for some reason, and there are a couple of good reasons for this to happen, but for some reason, sometimes the milk just gets too full and your breast will become engorged to the point that it's almost like it feels like a heart. It's just so tense. It feels like a cantaloupe or something on your chest. And it's so tense that even the nipple can be flat so that the baby can't even latch on. And that's not normal engorgement. So it's important to know the difference. Occasionally this will happen when all of a sudden your baby has slept for 8 hours and you weren't expecting that. And then those are good times to feel engorgement, but you need to get that milk out. If you don't get the milk out, like Dr. Macaluso was talking about, you're going to start, your body will start making less milk because it's seeing unrelieved pressure, and then you make less milk. So anytime there is milk filling up the breast, you want to just drain it. If it's uncomfortably full in this abnormal amount of engorgement, you'll want to get some help. You're going to want cold compresses and get that milk out. What else? Okay, so let's move on to the next slide. So the weight gain, I think one of you guys mentioned that the weight is one of the ways that we track how babies are doing. You can see as they are feeding, they're gaining weight. But in the first few days after delivery, there's always going to be weight loss. and babies just have a lot of fluid that's been transferred into them from the placenta, and they kind of pee that out. They have a diuresis after birth, and you're only giving them, as Dr. Macaluso described, tiny little amounts of colostrum. So they're not getting huge volumes of breast milk. They're getting all the quality, but not the quantity. So they do lose weight at the beginning. And that's why that breastfeeding log that Dr. Visentin went over is so critically important to use to see your goals. If your baby is losing weight and but you're getting all the urines and the stools, as is documented on the chart, you're not in any bad position. That's exactly where you should be. So it's important to empower yourself to get that knowledge on what's normal and what's not normal with weight loss, because you're going to get a lot of advice from a lot of people who mean well, but sometimes they're going to give you bad advice. They're going to tell you that the baby's losing weight, you need to supplement. But if you can feel comfortable knowing that the baby is actually lost a little bit of weight, but the black stool has already turned yellow, and I fed 10 times today, and I've had 4 wet diapers, and you can say, you know what, thank you for your advice, but I think things are going well. I'm going to keep doing what I'm doing. On the flip side, it's really important, though, not to just feed and assume that the weight loss is normal. Okay, occasionally there are medical issues that are going on with babies or with mothers that prevent babies from gaining weight well. And, you know, there could be low milk supply, and anything from the low milk supply in the mother to a difficulty of that milk being able to be transferred to the baby, or to a medical problem with the baby. So they're actually getting the milk, but they need so many calories because they have a medical issue going on. And so it's really important for your doctor to assess which of these issues is going on. And the way your job is to recognize the difference. So if your baby has lost weight and is on day 3 or 4 and still has the black meconium, that is not a normal weight loss. That's a weight loss with things not going right. And the goal there is to make sure that that baby is fed. And while you're feeding the baby, whether it's with breast milk or formula or milk that you've gotten from a milk bank, you need to not only feed the baby, but you also need to have a doctor who's going to help you figure out why. You don't treat the weight loss without addressing the underlying cause. And you want to figure out how to safely supplement. So the doctor who is breastfeeding supportive will be able to help you figure out, how can I safely grow this baby while we're working on figuring out the cause of the problem, and how can I supplement in a way that's going to protect the milk supply instead of undermine the milk supply. So those are all really important things for you guys to take out of this. Let's see. So next slide. So if you're not sure, it's really, really important for you just to reach out. And you want to be prepared as you are being prepared by taking a class like this. You might want to take a more in-depth class at your hospital or whatever you need. I really do recommend that you do a prenatal visit with Dr. Macaluso in particular, because Dr. Macaluso is super, super helpful in seeing patients from all over the, she only does breastfeeding medicine. So Dr. Macaluso will see prenatal visits for moms to address your individual needs. Whereas Dr. Visentin and I just see our patients that are within our own practice, and we're happy to do prenatals for those patients. But you want to find a supportive network, whether that's, a mother who might have breastfed, your friends and family, a pediatrician who's supportive of breastfeeding. It's a great question to ask the doctor when you're doing your prenatal interviews. If you plan to do a meet and greet with the pediatrician that you're going to hire. Ask them how they support breastfeeding. Many doctors have lactation consults in their offices, or they have a little bit of knowledge themselves, or they have a referral network. And then Dr. Macaluso, she was explaining about the 4th trimester. That period between birth and the first few months is really a dynamic period for the mother and the baby, and she's in a nice position to really help both and to work with your pediatrician. She's not going to be your pediatrician, so she's sort of a supplemental resource. And I think that, I want you to, I think there might be one more slide. Let me see. Oh, yeah. And then maybe one more, I'm not sure. That's how to reach Dr. Macaluso. No, okay. So before we get to the question and answers, I just wanted to say that it's really important that when you do get help, that you're focusing on your own individual goals. Dr. Macaluso mentioned this before, but we have only 2 rules here, and that is that the baby is fed and that the mother is happy. And anything, however you want to feed your baby, is up to you. There is no judgment. We just don't like to see women fail because of not being informed, getting bad advice. We want you to weigh the risks and benefits, see what works for your life, with your lifestyle, with your partner, and we just want to set you up for success. So don't see any specialist or lactation consultant who is coming at your situation with the mindset of what their goal is not the right person. You really, really need to focus on you. So congratulations to all of you. This is a very exciting time, and I want you to remember to enjoy your baby as much as you can. And with that, I will hand it back over to do some of the questions.
Thank you, everybody. The first question is, how do you get in contact with Dr. Macaluso? We will be sending that out in the email. Also, I believe you can find her at the alliedphysiciansgroup.com website. There'll be a link to Breastfeeding Medicine. And I'm sure if you Google Dr. Macaluso, you will find her immediately. And she is, and she'll correct me if I'm wrong, doing telemed visits, so it doesn't matter where you live. She is a great resource. Also, forgot what I was going to say, but Dr. Macaluso, did you want to add anything that I have forgotten?
I apologize. I think my internet went a little unstable for a little bit as Jen ended and you segued in. So I'm sorry I missed a little bit. But it's thrilling to have a practice where I can see everyone from every pediatric and OB and lactation consultant and people in the area referring. One of the thrills, not to say COVID's been thrilling because it's the complete opposite of that, but it's opened up a whole new way of life via telemedicine. So I've been able to reach people in out of state. I've gone as south as Georgia. I've seen a mom in the UK via telemedicine. It's really been an amazing way to spread more knowledge in this area. I think just breastfeeding medicine it's insane that we've had breasts since the beginning of time and it's normal physiology to do this, but the Academy of Breastfeeding Medicine only was brought into existence in the 90s. That is not that long ago. So a lot of us that are practicing this type of subspecialty, it is on the newer side. It's at the point now where I've gotten very passionate and very experienced in taking care of moms, because no one is really taking care of moms and the breast in medicine aside from cancer. So it's a wonderful practice to be able to diagnose and treat appropriately and meet a mom's physical, mental, and universal needs of mom and baby.
Thank you. All right, so let's get to some of the questions. A lot of the questions have to do with pumping. When do you start pumping? How do you pump? What kind of pump do you use? Nipple confusion between breast and bottle. Dr. Shaer, would you like to take this one?
Sure. So, if everything's going well, in the first 2 weeks, it's probably best not to introduce the pump and just let nature sort of work out the way it's supposed to work out. You know, if you think about it, your body doesn't know whether or not you've had triplets or you've had a miscarriage, right? So it only knows how much milk to make by what is being removed by the baby. And that setup in those first 2 weeks of how much milk is going to be made works best when it's on-demand baby-led feeding. Pumping in that early time really should be saved for when you're having a problem. If your nipples are sore or a baby's in the NICU or whatever problem you're having. After that, then there's tons and tons of time to talk about, pumping to get a break, to take a nap, to go back to work. It is so individual for each person of what their needs are. I'm sure that Dr. Visentin, Macaluso, and I have had tons and tons of like one-on-one consultations for just this purpose of trying to make a plan that works for you. And then depending on what your need is, there's a different pump for your need, right? So the people who are going to be completely pump dependent and they're going to want something that's super hardy. And then there are people who just need an occasional bottle because they're going to be stay at home and they just want an occasional bottle and they might need something else. So I'm definitely not brand loyal. And so I'm not going to tell you which particular brand. What I will say though, is that insurance companies will often cover a pump. So if you can get a prescription from your doctor, you can get a pump covered by insurance and you don't really get to pick what they give you. You get what you get, but it's certainly a nice way to get a free pump. Would you guys add anything about that?
I'm going to give a shout out. I'm part of a study that's going on, a pump study that we're doing through IABLE and the University of Wisconsin and Northern Illinois. And we're giving a survey. My practice is the launch pad for the survey where moms are inputting information on how they feel about their pump. We're also testing the pumps and we're trying to get published. We should be by the end of the year and create an app with evidence-based data-driven information to help you choose and utilize your pump appropriately. So we are trying to get more science and data and good measurements to share with you. So you're not trying to read on the internet what this person thought of this pump, and you're actually able to interpret it with science and research behind it.
One thing I would add though is not sharing. That's one thing. You really shouldn't use somebody else's pump.
Yeah. I don't know if you touched upon, I'm sorry about my internet. I don't know what's going on. I'm usually good here at home, but hand expression, some of you find it more comfortable to hand express versus use an electric pump during those early colostral days in the hospital. So like if someone's telling you you need to express milk day 1, day 2, before your milk is coming in more during the early days of colostrum, learn how to use your hands and feel free, obviously, to schedule visits and have us teach you and help guide you when that's needed.
I was going to add one other thing. There's, I think, a lot of moms see lots of things about lots of big freezers full of milk, and that there's a lot of different reasons why moms may have that. A lot of times it may be an oversupply. That is definitely not the expectation or sort of the norm that a mom should expect, that she should have a freezer full of milk. As Dr. Shaer had said, especially in those first few days, those first few weeks, your body is making what your baby needs. And there really isn't any extra that should be in the freezer. And so if you are truly nursing your baby on demand, your body is making exactly what your baby needs. And so I think sometimes there's a sort of perceived pressure that moms have to pump so that they have this extra milk in the freezer. And really in those first couple of days, those first couple of weeks, the focus should be on healing from childbirth, getting breastfeeding off to a great start, and nursing your baby on demand. And as Dr. Shaer said, if everything is going well, there really isn't a need to introduce the pump. Your baby is nursing quite frequently. It may take your baby 20 to 45 minutes to nurse. If you're doing that every 2 hours, you're going to change your baby, feed your baby, by the time you do all that, and there's not a whole lot of time in between the next feed. And if you're trying to squeeze pumping in there when you don't necessarily have a reason to, you may be creating some extra stress and some extra pressure that you may not need to.
Thank you. There are a couple of questions that I'm going to learn something from. One of the questions was, do you burn as many calories with pumping as you do with actually putting the baby to the breast in those first few weeks? I have no idea. Dr. Macaluso?
Yeah, you're still expressing and churning a life supply for your infant. So yes, you still do. And then obviously some people add that on. I want to follow up on Lisa too, because this has to do with, if you're obviously not latching and you're pumping, there is this more recent entity of people really pumping a lot and early and frequently, and that can lead you to a diagnosis called hyperlactation. And with that, you are much more prone to get what we call clogged ducts, kind of like Jen was alluding to, Dr. Shaer, the engorgement, uncomfortable, rock hard fullness, which is not a comfortable place to be. So if you are really over pumping, you're going to lead yourself and program your body to an oversupply, and you're much more likely to get clogged ducts and likely to set yourself up for possibly more frequent and mastitis or breast infections. So it's this whole area that you want to avoid. It is not normal to stock your freezer with 20 million storage bags and post that on Instagram. A lot of people think that's the new normal, and it's not.
And along with that, other than the risks to the mom, if babies are feeding from a mom who has this hyperlactation, they are frequently gassy, fussy, colicky, the type of baby that you just don't necessarily want to have. So it's too much of a good thing, sometimes not such a good thing. It looks like we lost Dr. Levene with the questions. I'll tell you, there's a question that I always get that I am going to answer, even though he's not here to throw it out. And Dr. Macaluso addressed the COVID vaccine, but before there was COVID, there were always questions about other vaccines. And I would repeat and re-echo the fact that breast milk is actually normal and not this liquid gold that is going to save your baby from everything. Your baby should be on the same vaccine schedule as every other baby, and that breastfed babies actually mount better responses to vaccines than babies who are on formula. So it's an even added advantage. I like to always point out that before there was even formula and everybody was either breastfed or wet nurse fed, there was still lots of infant mortality. And so breast milk is not going to save every problem. You definitely do want to stick with the regular vaccine schedule. I took a question myself, Eric, because we lost you.
Thank you. Yes, I lost my internet, but thanks. There's another question that I got. People were asking about how can they increase their supply. And that in the same question, somebody asked, and I'm going to learn something here. What if somebody has had pierced nipples? Since I think that's becoming more and more common.
I can go if you
Anybody
want.
Want to take that?
Yeah,
Okay.
yeah.
Thank you.
There actually are some studies on nipple piercing, which it can potentially cause scarring. So you will occasionally see a woman with nipple piercing on one side and possibly a lower supply on that side, or both. I have seen a lot of this over the years. It's not a definite risk of definitive low milk supply, but it's definitely in your head if you have a history of that. I've learned to take that history as part of my everyday history, because it's funny, you'd be amazed. A lot of people forget that they had their nipples pierced when they were 16, once they're 35 and having their first baby. They're like, oh yeah, I forgot that I did that. So it definitely can be a risk factor on milk supply, something to think about. In terms of, like, I know someone put in the chat bot foods or milk tea or other things you can do to promote supply. I think, as Dr. Shaer and Dr. Visentin, as we've all touched upon, I think tonight, it's so important to breastfeed your baby frequently and get your baby on. The number one way to make milk is empty your breast, make more milk. So nothing will beat out the dirty work of latch to get this done. It is grueling. Someone has to tell you this is going to be one of the hardest things you will do in life, mentally and physically, is live through the first 2 weeks of breastfeeding. It is not easy, but so important are those early days of programming your milk supply. It helps to predict milk supply at 6 weeks if you lay the groundwork in the early days. So major goal is the glory hour of that first hour of life. It's known as the golden hour of trying really hard to get your baby on right away, 8 to 12 times a day, as we talked about, and really trying hard to do that well, deeply, and drain well. If you are having issues, that would be an indication. Next would be other ways to drain, which would be hand expression or pumping, considering different ways of pumping, maximizing. This is another area that I think we're not spending enough time on. I'm learning more by being with this pump study, but making sure your pump flanges are fitted properly. A lot of people have no idea that the pump they get through insurance actually comes with 2 different sizes often of pump flanges, and they're using them interchangeably, not realizing that the diameter that your nipple gets pulled into is different. So you really want to go over with a mom what flanges she's using, make sure they are fitted right. They're not too small, they're not too wide. That can impact drainage and supply. And make sure that she's actually optimizing the settings on the pump as well. We're learning more through this pump study that I'm on of how to utilize each of the settings on the pumps and try to maximize those too. There is not a lot of strong science and data behind a lot of the supplements that are out there. I think the longer I do this for, I can't begin to tell you how many more gadgets and tools you see people buying and spending money on to make this happen. It's sad to see because I think a lot of it is unnecessary and sometimes sabotages your confidence and sometimes can make things worse. So I would try really hard to get hands-on help before you go buy all these tools and gadgets and supplements, because often there's other things we can do that would be much more imperative and important to make this happen for you other than these supplements.
Thank you. Now I have
Sorry,
one other question. Oh, sorry, go ahead.
I was just going to add one thing, I'm sorry, to what Dr. Macaluso said about feeding frequently and those first few days and those first few weeks. Newborns need to eat frequently, whether they're breastfed or bottle fed. So I think one of the other common things that parents, some of those myths are that if the baby is formula fed, that it's going to be easier and they're not, parents are going to get more sleep. Newborns need to eat that frequently, 8 to 12 times, whether they're breastfed or bottle fed. And so as Dr. Macaluso said, it's going to be difficult, but that is part of that adjustment to having a baby. And I think a lot of times there's a tendency to sort of blame everything on breastfeeding when that's a normal part of having a baby, is that babies need to eat frequently. That's a normal physiologic thing for them to need to eat that frequently. And one of the best things that you can do to establish your milk supply is to feed that baby frequently and feed the baby frequently at the breast. And then sometimes introducing that formula, people think that that's going to help, but it can inadvertently harm because then you're not removing the milk as frequently. So I just wanted to kind of make sure that everybody is remembering that sometimes there's a lot of extra blame that kind of gets put on the breastfeeding, and it's just part of adjusting to having a newborn and them needing to eat frequently.
Thank you. I'm going to ask Dr. Visentin another question, and this has been fairly common. What can partners do to help facilitate a successful breastfeeding? Certainly, there's lots of things partners can do.
Yeah, that's a great question. I'm glad somebody brought that up because there are a lot of things that partners can do to support the moms. So one of the best ways that I try to encourage partners is that initially their job is to help take care of mom so that mom can take care of the baby. So the partners can help by getting mom snacks, taking care of some of the other housework, changing diapers, doing any of the other baby care that's not that direct feeding. I know sometimes partners may feel a little bit left out because a lot of the care of the baby initially is breastfeeding. The baby's going to spend a lot of time breastfeeding initially, but partners can really help breastfeeding go well by helping to take care of mom, make sure that she is staying well hydrated. Moms don't have to drink excessive amounts of water, but you do need to stay hydrated. Breast milk is a fluid, and so making sure that mom has something to drink, trying to make mom as comfortable as possible. I learned a little tip from Dr. Shaer of having moms make a little nest where they're going to breastfeed, have their water, have their phone charger, just kind of get all those other things that that mom needs, so that when she's nursing, all of those other things are in easy reach for her. And if the partners are really thinking about initially, their job is to take care of mom, so that then mom can feed the baby. That's a great way for them to support the breastfeeding mom.
I just want to add that, when my wife was breastfeeding, that bath time was my time. That was when I got to bond with the baby. And that I did almost all the baths for years. And actually, it's fun. And it was my time to bond. So if partners are feeling left out, find a different way.
Yeah, that's great.
Cool.
All right. I think that's most of the questions. There are some other questions that we're just not getting enough time to get to, but I recommend making an appointment with Dr. Macaluso. You do not need to be an allied patient. Your child doesn't need to be an allied patient to see Dr. Macaluso, although we will encourage you to find an allied practice near you. You can go to the alliedphysiciansgroup.com website, and it will help you find some practices near you. We also, for new mothers, we have the new parent helpline that you can get the information on that website. We actually have a person there to answer a lot of questions for you, help you find allied practices near you. And with that, I think we are pretty much complete, unless somebody else has something to add. Brianne?
No, that was wonderful. Thank you to all the speakers for taking the time to talk us through it and inform us. We really appreciate it.
Thanks for having us.
Our pleasure.
I hope
you.
everyone has a great night and good luck.
Hey.
Right.